Good afternoon, ladies and gentlemen. Welcome to the webinar on mental health crisis and acute care. My name is Tim Briggs and I chair the GIRF programme. And as many of you will know now, the GIRF programme started in orthopaedics, it was my own specialty, but it's grown into a national programme with 41 work streams led by 66 GIRF leads who are well renowned and respected. To date, we've produced 31 national reports. Another 6 are going through the process of sign-off, and we've got a further 4 to go. And many of these reports are being published just when we need them, and I think today is a real case in point. This report has been written by Dr. Ian Davidson, my clinical lead for mental health crisis and acute care. And as we know, I think it's very timely because COVID has been very tough for many mentally. And Ian has shown, as a result of COVID, there's increasing demand, and that there's also disproportionately worsened the mental health burden for the most vulnerable. After carrying out virtual visits with benchmarked data and fully supported by the professional societies and stakeholders, it's a pleasure to be here on this webinar introducing this report. What is amazing to me reading it is that mental health problems represent the largest single cause of disability in the UK, with 1 in 4 adults experiencing at least one diagnosable mental health problem in any 1 year. And it's also said that as a result of COVID, there's an additional 500,000 people experiencing mental health problems. What Ian has shown is 17 recommendations, all dealing with data and limited use of outcome measures. And so I think this report is very welcome, especially with the increased investment funding for mental health services in the long-term plan and the mental health investment standards, which GIRF actually welcomes. So I look forward to hearing more about this report and look forward to Ian enabled to implement his recommendations. So thank you very much indeed. And again, congratulations, Ian, a fantastic effort. Thank you.
And I think it's now me. Thank you, Tim. And like Tim Briggs, I'm Tim Kendall. I'm the National Clinical Director for Mental Health. And like Tim Briggs, I'm enormously pleased and proud of what Ian and the team at GIRF have achieved. This is a really, really important piece of work, and one which goes absolutely to a place where I've been very actively engaged in my career. So perhaps I'll just briefly tell you where that is, or where it was. Out of area placements in Sheffield about 10 or 12 years ago, probably a bit more actually, more like 13 years ago, out of area placements were such that we effectively had 2 wards full of people out of area at any one time. So that's every day. So 60 people, costing our CCG a huge amount of money. You know, these are beds that cost a couple of £100 per person per year. So, you know, this was not cheap. Now, I went to our CCG and said, you know, if we could get this down to nothing, can we keep the money that we're spending? You know, the bargain here would be high quality care. So that's essentially what we did. And I'd worked out that if we could drop the length of stay on our wards from the 50 days that it was down to 30, which was the national average, we could, we would save 40% of our beds and we could bring everybody back immediately. Now, I had several years of experience of failing at doing just that. And there are lots and lots of reasons for it. We knew that we could bring down the lengths of stay by enhancing discharge, by reducing admission, by ensuring we've got rehab exits, that we've got right housing solutions, etc., etc. But so many things worked against it, and it took some while before I realized and all the others working with me realized that actually this was a whole system problem. It meant you had to have the crisis teams on board, you had to have the ward staff on board, you had to have had to have all the managers, all the board, everybody had to be involved, and you needed a data rich environment. And I think we managed to not only bring down our out of area placements, but we managed to bring down the bed numbers on wards from 24 down to 18. Big reward for the nursing staff. They found themselves thinking, great, 18 beds, same amount of staff. Yeah, so it's like an investment of 1.6 million for 4 wards. So it was a really good experience. Now, when I met Tim Briggs, and he said to me, I want some GIRF programs in mental health. I want at least 3. And so I said, okay, leave it with me. First thing that came to mind was, could we help everybody deal with this out of area placement problem? And so it was that Tim and I both agreed one would be out of area placements for children, and that was a big problem. Another was out of area placements for in locked rehab, and then the third one was this one. It was out of area placements in acute care in mental health. Now, I've been National Clinical Director for 6 years, I think, thereabouts, 5 or 6 years. And we've got the long-term plan since Tim and I first discussed this. And the long-term plan, in essence, is basically saying we now want to provide as much of the care as we can as locally as possible. Don't provide care out of area. Provide all your care within area, and where you can, provide it in people's neighborhoods. So mental health teams are being invested in neighborhoods. So in a £50,000 PCN primary care network, we're investing £1.3 million for both community-based care and community-based crisis care. And our aim for this is to get to the point where there is as little pressure on the acute care pathway as possible. But the acute care pathway, we would like that to be less heated. And I believe that what Ian and the team have done is going to give people the chance to really get a grip using data, using the relationships that they develop in collecting that data and so on, to really get a grip of the acute care pathway and make sure that we can provide care within the locality, within the place that people live. So thank you, Ian, for all the work you've done. Thank you, Tim, for making this possible. And really pleased to see nearly 400 people joining us today. So thank you very much.
Thank you, both Tims. Thank you very much for that. So we've got a packed program today, so I'm going to go straight to screen share. Okay, so it's my name as the chief author, but like all of these things, you don't do anything on your own. It was a whole team working on this. We've had contributions, as Tim Briggs has said, from people in deep dives and all sorts of other things. We've looked at a load of data. We've had a lot of analysts working with this, but we've also been built on a whole range of other stuff, and reports that were published in the past. We've linked it into the long-term plan, and it's going on with work in parallel now. So this is part of a whole wide thing, but it's a particular focus on it. So we've got 17 recommendations in all, as Tim said. We've got 3 overriding themes, one of which is analysing and reporting outcome measures. You cannot actually say whether or not you're cost efficient or cost effective if you're not saying what you're delivering for the money you get. So absolutely critical is getting to the point where we're using and publicly demonstrating outcome, and we'll go on to how that can be done. You need to be making sure it's right first time. As Tim Kendall said, trying to do things like reduce out-of-area beds. It's been an ongoing campaign for a number of years. I was part of that work prior to coming into GIRFT. And what became very evident from that is you cannot sort out inpatient bed problems by simply looking at inpatient beds. You have to look at why people present at that stage and what's the outflow from those beds, which is why we chose to take this whole pathway approach. And what we became even clearer then was that front door access is critical. If you get a good first assessment of the first point of contact and that follows through with you, then most of the other problems become much easier to identify and address. And then finally, there is a need to use proven flow tools in both community and inpatients. There were an awful lot of people stranded in community teams and stranded in inpatient services where it was not clear what was being beneficial to them, how their outcomes were improving, what was the purpose of that, and how to achieve it. And where that was reversed, i.e. there was a very clear purpose and the person knew what we were trying to achieve, the team working with them knew what they were trying to achieve, flow was much better, which meant access was better, which meant more people got treated for the same resources. So this is the critical bit of it. The program scope, so it's 1.6 million adults a year access the services. It's basically all the core, what used to be called core community and acute inpatient beds. And there were the deep dives to explore variants. So we were not a regulatory body. We were not judging people. We were going to people and saying, this is where you look higher than average in this or lower than average in this. What does that mean to you? What does that mean in terms of what we can learn about what's best practice and how to disseminate that around the country? Won't go into this. It's in the report, but this is absolutely critical. Route one is if you're unwell, you know you need help, you go and seek help. Either primary care can meet your needs, or if they can't, they will pass you on, if you've got SMI, serious mental illness, into specialist mental health services. There will be no delays, no bouncing around, no being told you're not right for us, or you come through the wrong door, or please go away and come back next week. You will be maintained in service between days to years, depending on what your needs are, and you'll either go back to being resilient, i.e. able to cope with life without needing health service input, or you will move on to where you can function very well with primary care input and IAPS and all the other things that are available in primary care. Route two is those people who try to do that and for one reason or another fall through the net. And route three is people who have no confidence in the system at all or don't believe they're unwell and they end up. 73% of suicides in England are still from people who have not had contact with specialist mental health services the previous year. That's a phenomenally high number not in contact with services. And it's a clear indication that we have got a long way to go in terms of being able to help people get access when they need it. If people present down in that bottom right-hand corner severely unwell, requiring high-intensity services, they tend to have acquired secondary and tertiary damages, and that makes treating them much more complicated. It means that they have got much more to sort of unlearn and relearn again, and it means that great chunks of their life have gone by. People with serious mental illness die approximately 15 years earlier than the general population. They also have 10 to 15 years of extra severe illness burden. Most of that is preventable by early intervention and effective treatments early on. These are areas of focus. I won't go on to those, but it's just to give you an idea of the sorts of issues that we looked at while we were going through the program. This is an example of how we try to use data. So one of the challenges was that people were saying, oh, the problem is there aren't enough beds. The problem is that those people who say they've got enough beds are faking it because they're sending lots of people out of area or sending lots of people into rehab. And anyway, it's a national problem. What this clearly shows, so to the right is higher beds per 100K. And we use WID at 100K because we know deprivation is a huge driver of mental health need. To the left is lower numbers of beds per 100K. Above the midline is longer length of stay. Below the midline is lower lengths of stay. The people in this bottom left-hand quadrant, apologies, what we were being told is, well, they've just got lots of people out of area. They've got lots of people in rehab. So we added in the out of area, and as you can see, it doesn't change the picture. It shifts the axis slightly, it doesn't change the picture. And when we actually analyze it, those services were also sending fewer people into long-term inpatient beds, such as rehab. In other words, there is an example here of how you can do it, and you're going to be hearing from one of those places later on today as to what makes the difference, that people don't need to end up with long lengths of stay. One of the things COVID has made it easier to explain to people is that long lengths of stay in inpatient beds are actually very harmful. We know that in physical health for older people, but it's true for all mental health as well. And being cooped up in your home, not being allowed to go out when you wanted to, and not being allowed to mix with people you wanted to, was detrimental to people's mental health. It made some people ill who were not previously ill. It made a lot of people who had previous illness get worse. But if you're cooped up in an inpatient unit with very restricted ability to get out, mix people, having to stay and follow rules that don't apply to you, it also damages your mental health. So that's been a key driver in the findings, and that links into the long-term plan and the work you're going to be hearing about from others as well. We were able to identify a range of key metrics which indicated that our access issues, and if these sorts of access issues are there, you are going to struggle to be able to provide that easy in, easy out, short spells of hospital admission. You're going to end up with more people coming in a worse state and more people with more secondary harm, leading to longer lengths of stay. These are all things that can be identified and all can be fixed. Again, turn flow rates, we were able to identify a range of metrics which indicate flow rates. And again, these are all addressable, and we can cite good examples of how to do that. And again, they link into a lot of the work that's going on with the long-term plan, and you will see a lot of this stuff reflected in that. Because we've been interactively working with NHSEI, other mental health teams and LDA teams, and also with DHSC around this, both prior to the report being completed in March and since the report being completed. Right. So what's new? Well, 1887 is the first landmark. That's the first attempt to benchmark mental health services internationally. It's across the whole world this person tried to do it. And what they found was there was too much data, but it was poor quality and very little analysed, which is not unsimilar to what we find now. They also found there was a lot of qualitative information, which is important, but over-reliance on anecdote rather than looking at good quality routine data. And moving on now, we've started to use data, but 10 years ago, we were still using averages for everything, and those little up arrows and down arrows and boards were looking at, oh, it's gone up this month and down that month, like a schoolboy football team, you rush from there to there. And we've moved on from that. There is no magic pipeline of suitably qualified staff. We have to use the staff that we've got to best effect. We have got vacancies across the country. There is no pipeline that's currently producing enough people to fill those vacancies. We have to use people to maximum effect. Capacity and demand has been rising. Won't go on to this. This is so you can read it afterwards, but these are the things that we took into account in all of the stuff that we're doing. What will be different? Long-term plan is a whole pathway approach, timely access. Bottom there, can we do it? Yes, although we are not where we want to be, there are examples in all of the areas that I've just mentioned and everything that's mentioned in my report. We can give you examples of it being used. Stuff like run charts and SPC, which were unheard of 5-6 years ago in mental health, are now fairly routine. We're using data to challenge myths and legends. We're using sentinel metrics, dashboards you're going to hear about later on coming through, flow tools and outcome reporting. They're all happening. They're not happening routinely enough, frequently enough, but they are happening and they're building. What will be different? Well, people who access services will be treated as equals and partners. They will be given copies of their assessments so they can check and correct them, and so that they can see that what they have said has not only been listened to, but heard correctly. They will be given real information on real-time outcomes and potential benefits and harms of any intervention. They will be accessing services, but not be all the time asked to repeat their history. All the things that people told us were really important to them. There are more there, but I'm carrying on because I've short of time. Thanks to everyone. Very quick run through. You're now going to hear a number of practical examples of that, but we have loads and loads. If anyone wants me to talk to them about any of the specific recommendations or any part of the report, we are available. We are doing lots of work. We're doing regional visits now, as well as follow-up to trusts and things. So happy to talk to anyone. Thank you very much for listening. What I just repeat is what was said earlier. And Michelle's monitoring the chat. So if you've got questions in the chat, that's fine. But for questions that you want to put to the panelists, and if you put them into the Q&A, then when we get to 1 o'clock, we will be able to answer those. And any we can't answer, we will follow up on afterwards. Thank you very much. Rapid run through from me. And over now to Ian McCafferty, Clinical Director in Solent Mental Health Services, who's taking on the next one. Sorry, I'm wrong. Amanda Thompson. Sorry, Amanda. National Specialty Advisor for Older People's Mental Health is next, and I apologise for that.
Okay, share. Just coming. Hopefully this is. Can you? Can you see the slide? Yep, okay. So I want to spend a few slides setting the context. And so thanks, Ian, for the great presentation. I'll start by reminding everybody that our population is actually aging. And that it can only be considered a good thing. One considers that if it wasn't aging, we'd all be dead. So this increase is particularly noticeable in the older olds, those above 85. And I'd urge you, if you haven't already seen it, to watch the HE video on the demographic changes. My colleague will put the link in the chat. So with a predicted increase in older people to 1 in 4 being over 65, it's essential we get care right for them. I want to summarize to start with by saying where we were when we started this. So this is the UN report in the summer estimated that every second person in the world holds moderately or highly ageist attitudes. While I'll be focusing on older people, clearly it can also affect younger people. We know from studies that for older people, ageism itself is associated with a shorter lifespan, poorer physical and mental health, and slower recovery from disability and cognitive decline. Previous reports by the Royal College of Psychiatrists, as indicated on this slide, has demonstrated historical underfunding and lack of investment in older adult services. And there has been interesting research where health professionals are given mental health care case studies, similar in all details but age, and they're less likely to correctly diagnose and treat older people. So this slide is based on a national stocktake we did of older adult mental health services, which was completed by all mental health trusts in early 2020. In case you haven't actually seen your local data, it was broken down into STP ICS level reports and distributed to the clinical networks. So if you want to see it. As you can see, there is considerable variation between the mean length of stay for providers, with the average length of stay being 76 days, a slight increase from 2018-19. But what it does show is that 12% of patients stay less than 2 weeks. And as Ian said, it's a bad place to be an inpatient if you're an older person. 30% of patients stay for more than 90 days. And these patients make up 63% of the occupied beds. So with our current data, more up to date than 2020, 9.4 people per 100,000 older population are staying more than 90 days. This isn't all about dementia. 55% of people have functional mental illness. So with that, what are some of our recommendations? Well, like Ian has already pointed out, if the length of stay is particularly long, we would recommend having a system in place to regularly review those who are long stayers and optimize flow. You could use the red to green or similar flow methodology, but it's particularly helpful to highlight in your local area what are the barriers to discharge so that they can be overcome. It could also be worth you reviewing the level and skill mix of the staff on the ward. Are you waiting for assessments? And consider using the investment monies allocated to improve the therapeutic offer in inpatients. But obviously this will have to be determined locally based on all the inpatient needs across the system. If your local service is running into difficulties with discharge, you could consider applying for some of the money available to support discharges from hospital. The funds can be used to help people cope with daily routine, tenancy, finances, or maybe accommodation. Now, we've got to also remember the short stayers as well. And if the stay is very short, what were the community alternatives? What could we have done that could have avoided this omission? And it's really important that older adults are able to access appropriate communities crisis support. Finally, if your occupancy levels are consistently above 85%, you're really at risk of the staff burnout and have a reduced ability to meet the changes in demand. The reason behind high occupancy are most likely to be related to this flow issue across the whole system. So it'll be important to review your community capacity. I have heard of people, colleagues, being told that they're not wanting to focus on the community, but just the inpatients. It can never be one or the other. It has to be both. So moving on to a community urgent and acute mental health service. As Ian says, this is about using data to understand your local older population needs so that services commissioned accurately reflect these needs. We know that some local areas have a predicted older adult population increase of 32% by 2035. It's clear in the long-term plan that the crisis offer applies to older adults. I'm sure everyone on the call knows that, but they should be able to access 24/7 crisis resolution home treatment service. When looking at crisis services, it's also important to ensure that staff have the competencies to meet the needs of older adults. And this will involve assessing the older adult mental health training needs of the workforce and making a plan to meet these needs. Once again, when planning how to address any training needs that are highlighted, you will have to factor in the time that will be needed to develop and deliver the training. Accessibility to crisis services and support is key, and it's important to work with your local communities to ensure that any potential barriers to access for any part of the older adult community are identified and then addressed. We know of an integrated care system who undertook the data analysis, which revealed that few older adults were accessing their crisis service. So they went back and they're redeveloping alongside older adults an offer that meets their needs. Also, as part of the community mental health transformation, it's important for older adults mental health services to work with their local urgent community response and virtual frailty wards, as these are services most likely to involve older people. So the take-home messages, well, firstly, as it's been said, it's important to have comprehensive and accurate data. Surprising how many trusts had not got 100% ethnicity data. And when thinking about how you're going to meet the mental health needs of older people, not only do you have to ensure that older people who traditionally face greater barriers to access are not being additionally disadvantaged by any solutions you come up with, but you also need to have to think about the experience that they have and make sure it's high quality. And that will involve looking at the skills gap. The stock take shows us that there is a skills gap, and it will need to be assessed locally to make sure we can meet the older adults' needs. And finally, I specifically ask you to consider older adults with mental health needs because sometimes they are forgotten. So this is the futures page, and I would urge you to look at that if you want to share best practice. And I'm going to hand over to Ian.
Thank you, Amanda. Just a reminder to everyone, if you put stuff into the question and answers, we'll pick it up when we come to the panel session at 1 o'clock. So the next one up now is Bobby Pratap, who's Deputy Head of Mental Health, and he's presenting on behalf of Johanna Freeriks about the Mental Health Act dashboard. Thank you, Bobby.
Thank you, Ian. And thank you for inviting me. I am very largely presenting my colleague Johanna's work, as Ian mentioned, who couldn't be here today. But so if we can move on to the first slide, please. And Ian asked us here today to talk in particular about some new data reports that we've got on the Mental Health Act. And I first want to say, I guess, that I think it's been quite astonishing that that we haven't had routine monthly data available at a national level, at patient level until now. We've had and been grateful for kind of annual reports from CQC and NHS Digital, unofficial reports from NHS benchmarking that are kind of they're not patient level, but our analysts have done a brilliant job on once they've had been able to get their hands on the mental health services data set. We're now able, or they are able, to churn out many dashboards, and this is one example. The first, and I'm just sharing here some screenshots. We were going to do a live demo, but I decided against that. But there are lots of other tabs on this dashboard, in addition to what I'm showing you today, on the future NHS space, and the links are in the presentation. But the first one is, so if you can see the red line, that's total admissions of any type to mental health services. And the blue line are admissions under the Act. So we can see the time series over time. And I think we see a slight increase at the time of the pandemic. We can't see the dates here. And I think that's kind of been maintained. So mental health wards have a slightly higher proportion of people detained under the Act post-pandemic than pre-pandemic. You can break down your local, if you look along the top, there are tabs here that are interactive. You can break down the data by region, ICS, provider, even provider type, so NHS or independent sector, age, and others. And I reiterate, you can, if you've got an NHS email address, you can go and see all of these data on the future NHS space, and I'll share a link and how to get on it afterwards. The graph at the bottom is a benchmark chart of proportion of admissions by provider, and sort of in line with some of the GIRFT principles. This is, I think, where it gets really interesting and where it enables local areas to question what's happening locally. The kind of two narratives we hear around this are, if you have a high percentage of people admitted under the Act, it might indicate that you're meeting loads of needs in the community, and you're only seeing the very most unwell people in inpatient wards. But on the flip side, if you're not sure that your community services are that well developed, it might indicate real pressure, and that actually you've only got capacity to see the very most unwell people, and there could potentially be more space for seeing for voluntary admissions. We can't make judgments from a national level. We can only share these data, and I think it's for every area to look and interrogate their own data, but there is a really huge variation here. If we go to the next slide, another different kind of benchmark or use of patient level data here. This is, again, I don't think a lot of what's in here will surprise many people, but it has largely been annual data at a national level and a lot of anecdotes. And this is the first time we're able to make that anecdote into data. So this is use of the Mental Health Act by ethnicity. Again, you can break down into your local areas. We have also got more ethnicity breakdowns on another tab I'm not presented today. So these are grouped ethnicity, if you like. So grouping Asian and Black and White British and other together. You can have, there are about 20 ethnicity breakdowns. I just want to point you to, so Jackie Dyer, our National Inequalities Advisor, specifically asked us to look at Section 135, and she wasn't wrong that it's something we need to look at. So obviously this is where police are going into people's houses, very restrictive practice. Some would feel intruding into their houses to detain them and to keep them safe. But we can see here, so the sort of dark blue line, the 17%, which hugely disproportionate of Black people have 135 by the police applied to them, which lines up with the anecdote that Jackie thought. And then if you look down to the bottom, a big question we're all grappling with is, how can we encourage people, Black communities, to engage with services earlier? Often what they will tell us is we don't want to engage because we know that if we do, we're going to be subject to community treatment orders, to conditional discharge, and so on. So, and we can see that huge, I mean, I knew it was disproportionate. I think we all knew it, but this is more disproportionate on some of these sections than I thought. Maybe it's not a surprise to others. But you can, again, I would very encourage you to go and look at your own data on this. If we go to the next slide, another couple of breakdowns I'm going to show you. So this is deprivation. We've broken down by section into quintile. So if everything were proportionate, there would be 20% applied to each quintile of deprivation. But again, probably not unexpected. We can see that if you look at, say, section 135 and 6, or the CTO, some of the short-term orders, around 60% of detentions are for the two most deprived quintiles, and sort of around less than 10% for the least deprived. Sorry, and again, probably not surprising here. But once, as ever, these national data do cover up a lot of local variation. So there may be all sorts of different things and sort of calls to action based on these data, based on your local system. We move to the next slide. And this is one we're treating with a bit of caution, but I think this is the first time, and I might be wrong, that we have looked at Section 136 per 100K population in a benchmark way. Big caveat is that we don't know yet how reliable, and I suspect it's not necessarily yet consistent and reliable, that mental health trusts are flowing Section 136 data to the mental health services data set. And a lot of it, I think, in some areas will be held by the police. But from what we do have and from what trusts are flowing, we can see massive variation. I don't think I'm breaching any confidence or anything, but that top bar is London. And I've had discussions with the Met Police that there aren't enough places of safety. And I think the challenge back might be that if people are being detained at the rates they are in London, I don't know that there will ever be enough places of safety and potentially not enough beds. And actually, we need to, I think there's a big call to action in that area to look at how our, both on the police side, how our police, what's their training, how are they detaining people appropriately, but also how our mental health services providing support to the police. Are mental health services responsive enough? We've all gone through the crisis care concordat, and we know that good joint working can reduce these rates. But a more stark or a more bigger variation, if you like, than I thought on 136. But if we move to the next slide, there's a couple of final breakdowns. So these aren't to do with the Mental Health Act, but just showing you another example of this is the next two slides are a particular ICS who we were supporting with their to look at their urgent and acute pressures. And what you can see here, this is the emergency care data set, and it looks like actually this area is doing quite well relatively in meeting crisis needs outside of A&E, relatively few attendances compared to most of the country. So it suggests something right might be going on in their community crisis pathways. And you can see they're about average for long waits within once people are in ED. If we move to the next slide, please. So this is when we were looking at how they benchmark in the MHSDS on admission. So again, their actual number of admissions per 100K and people who are admitted without any previous contact, benchmarking kind of relatively average to low, suggesting again, they might be doing something quite well. We don't know for sure, but in the community. However, when we look at their bed days, their length of stay and their discharges, it looks like this should be the area they might want to focus on. It looks like their flow out of the inpatient wards. Again, we might suggest unless they're able to resolve that, there might never be enough beds in this area, even though they might be doing quite well on the community side and preventing people coming in the first place. So we've sent these packs out to every ICS, and they will very soon be available on the future NHS dashboard. And our analysts are doing brilliant things like making statistical process charts you can see over time and all sorts. So if we move to the final slide, you can see that we've got links here for these dashboards, the Mental Health Act dashboard, urgent and acute dashboards that are being developed all the time. So please do keep checking back and do register on the platform and find them in the adult mental health space on these links. And that's it from me. Thank you, Ian. I'll hand over back to you.
Thank you, Bobby. And don't forget to put your questions to question and answer, and we will come back to them. What we're trying to illustrate here is that the range of data that people can look at and can be broken down, because one of the things we found in the GIRFT is that many areas weren't looking at this data. So there are lots of questions will come out of it, but we will be able to help point you in the right direction. Right, the next person then is Ian McCafferty, who is the Clinical Director for Mental Health Service in Solent, and he's going to talk to us about the work they've been doing down there on pathways and best care. Thank you, Ian.
You have those slides. Okay, that's good. Well, as we've talked about already, this is all about data, collecting data, getting data right. I'm very much going to try and not share masses of data with you and talk about a culture without data. And if possible, of a 104-page report, just share 1 page with you. So I hope you can understand. I'm doing it slightly differently if I can. So having started by saying we're talking about positive risk taking, that's exactly what I think here in Solent we don't do. You can imagine the reason I've been asked to talk is because we are slightly different. And I think we're largely different because we don't see inpatient care as trying to avoid positive risk taking. So this is the page I was going to share with you. There's masses of data on that 1 page. You can't imagine how much data there is on 104 pages. I'm just going to pick out the bits that are important as far as I'm concerned. The top blue arrow is that in terms of beds per 100,000, we don't have that many. So low 7 out of 57, quite a low number. The bottom blue arrow, the length of stay for the Mental Health Act stays, 18 out of 45. Clearly that's at the bottom. There's only 5 people lower than us there. But the one we're going to primarily focus on, if we can, is the red arrow, which is length of stay, including leave, of 14 days. We've got a mean in the country of 35. That's not 3 times to the mean, but if that's the mean, you can imagine how many multiples that is to the person who is at 56 in the country. And I hope that is roughly what we're talking about. In terms of an extra bit of information around that, those acute admissions, 1/3 of our admissions are home within 3 days, which is a dramatic piece of work, which makes us different. And always I get challenged at this point with regard to coming in and coming out of hospital. You must have a great crisis team keeping people out. You must have a great crisis team allowing people to leave earlier. And that's the information about our crisis team. And it's disappointingly dull. We see the same number of people. We've got slightly less staff, not significantly than anybody else. So our crisis team is not, check the door behind me to make sure they're not listening, horribly normal. And that's where we get to, is we are clearly an outlier. But I think we've got to be really, really careful that we don't think outlier is the same as delivering better care. Outlier, 2nd out of 57, makes you different. Does it mean better? I'm going to get statisticians in the audience telling me I'm using wrong words now. I'm young enough, I've got young children who asked me what I was talking about. And I tried to explain outlier to them, and they said I was an extremist. Now, extremist obviously comes with associated terms from the past. I suppose that was votes for women. That was anti-apartheid. Now, clearly, extremist has very different meanings altogether, but it's also situation specific as well. I mean, in the States, it's not in any way extremist for everyone to carry a gun. Here, by time, length of stay in asylums was probably better measured in decades, whereas we're now beginning to get to the stage we're almost measuring by hours. So just not confusing ourselves or you that being an outlier makes us better. It just makes us different at the moment. Now, we don't try and do anything particularly dramatic that I don't think everybody else is trying to do at all. These are really simple, structured, I hope, largely nationally targeted things to do. Least restrictive, obviously that's not a choice. The law tells us we must be least restrictive. Looking after our staff is, I think, really massive here in terms of being culturally different. So best working for staff, that's the bottom one. And clearly we're going to justify ourselves as being evidence-based, which is the top one. Now, Tim also spoke at the start about out-of-area placements. We've had none in the period associated with this data. And with less than average beds, that's quite impressive, I think. I'm proud of that. And we do care in the community. So we've not got anything special with our aspirations, but we'll drop in at the bottom that whilst that's not an aspiration, it's something we have to be insightful into, that's what we've got to deliver in a new world that lives in a financially measured way for everything that we do. So having said that we're different and been very proud of being the second out of 57, we now get to a different measure in terms of acute readmissions. And again, we become extremists here in terms of readmissions within 30 days. We are very high in terms of how many we get. 13% of our readmissions, 9% nationally. And then you look at that and you think, is that really high? That's only 2 or 3% more. But let's question that. Should those people have been at home whilst they were well enough to be at home in that gap, or should they have been in hospital with a target of making them fully well so that they would never be readmitted? That's a question that clearly I'm asking with a bit of a loaded question. Is it better or worse for patients' health to go home, to try and be well and come back? The demographics of this group of patients, I haven't got data for. Anecdotally, which is pretty poor data, aware of that, I think there's a lot of personality disordered based patients there. The EUPD group come into that box, and they're the box that go home within 3 days. Is it good for cost? Probably not. It costs money to admit people to hospital. It costs medical healthcare time. It costs admin time. It costs all sorts of time to admit people. Is that good for cost? Possibly not. So having validated ourselves almost as being good, then just acknowledging we're an outlier, and making sure that that necessarily isn't best care. So having said that it's not a crisis team that keeps us in that box, bottom left, that I think you showed us before, Ian, I think this is the culture that's different. Positive risk-taking is something that I've heard in my career, now probably decades, that we will make positive risks. Unfortunately, taking positive risks for someone, particularly if someone's detained under the Mental Health Act, you are making that choice as their responsible clinician. Asking people to come to work and take risks every day is a different request than anything else in any job I've ever come up with. So the phrase positive risk-taking, I and the trust have real problems with using that as a way to work. Bringing people to work and asking them to take risks for us, please, is not healthy. The idea of positive risk-taking is clearly right. Making decisions so that people can be at home, so that people don't stay in hospital for longer than is necessary. The idea of positive risk-taking is great. I think the phrase is actually really quite harmful, because what we would call a patient-centered safety plan, which is the box on the right, has all of the words that, if you like, I'm trying to talk about today. It's about people sharing decisions. It's about decisions being seen as an outcome. It's being able to look at this data between us all within the trust, and at that time feel good that we think we're doing the right thing. Asking people to take risks on a daily basis when they come on shift, I think really affects morale. It's a problem that I've seen anecdotally in places that I've worked, and it's difficult. I mean, we're lucky enough to have a fully staffed inpatient unit on both sides for nursing. We're one consultant short on adult mental health at the moment, but please feel free to apply if you want to work somewhere that takes patient-centered safety plans rather than positive risk-taking. So basically, I think what I've got to say is we are an outlier. We have small numbers of beds, lots of admissions. They all go home relatively early. Some of them come back. Is that a problem? We'll consider that, but it's something we're aware of and we know. So ultimately, if you read your own report, once you become an outlier, you get 2 dots in the column to say you are different. And I think if you get those dots, you need to look at them. And I would suggest ask yourself why, or am I happy? And that's all we've done in Solent. So ultimately what we haven't done is massive changes in the community and our crisis team in 136 assessments. We've just taken a culture that is, I think, the outlier. Thank you very much, Ian.
Thank you, Ian. And I guess repeat, please put questions in the question and answer box. We'll get back to that. Everyone's doing very well at keeping to time, so we've got plenty of time for questions and answers. One of the things that crops up time and time again, one of the things we've challenged, not just positive risk taking as a term, but people who are difficult to engage or people who want to engage. In all the GIRF talks, if you've been to my GIRF talks, we're actually talking about why are we failing to engage people rather than why are people failing to engage with us, because we're the ones paid to do the engagement. And the next talk is all about that. It's all about how we actually work with people and engage with people to ensure that health inequality is reduced. This is going to be a team talk from the Leicestershire Partnership. Rosie Clare, who's the project manager, project lead, who's going to lead off, and the others will join in. Thank you very much, Rosie.
Thanks, Ian, and also thank you for inviting us today. So what we're going to talk about is how we are trying to address the health inequalities within Leicester, Leicestershire and Rutland. But before we talk about the work we're doing towards reducing those health inequalities and also the engagement work we're doing with our population, we felt it was really important to give you some information and context actually about the makeup of our local geography and the population. So with me today is Helen Perfect, who's the Head of Service for Inpatients, Urgent, Emergency and Access Pathway, and Louisa O'Reilly, who's the Communications Manager. So if I go into the next slide. So as you can see, we sit right in the heart of England, and I thought it was quite helpful to show a map of, so the city is here in red, and then we have the county, which goes from Melton all the way across into Oadby and Wigston, and then Rutland kind of sits on its own. So I'll just kind of talk about each of the regions. So overall, we have a population of 1.1 million people, and it covers about 833 square miles. So it's quite a diverse kind of makeup. So it's diverse actually in terms of ethnicity, deprivation and health needs. So Leicester actually is the 9th largest city and one of the most diverse cities actually in England. So if we concentrate just on the city, it has a lower population of white British than the England average. It's also the 32nd most deprived local authorities out of 317 in England. So deprivation is aligned with the with average of poor health behaviours and outcomes, which in effect affects people's mental health. So 28% of people living in the city have said that English is not their main language, and that's against the England average, which is 8%. So that in itself does kind of pose some challenges for us in terms of communicating and being able to provide the right service. So Leicestershire, it's made up of a number of urban areas, actually, towns and large villages, and it has got some rural areas as well. But majority of the population in our county actually belong to a white ethnic group. The next highest group is Asian, which is at around 6.3%. So Rutland, here on the grey bit, is actually very sparsely populated and has 2 market towns. And the vast majority of that population classify themselves as being white. And that's about 98.2% actually of that population. So that we wanted to just kind of give you what the makeup is like and how kind of diverse our county is. I'm now going to hand over to Louise, who's going to talk through some of the work we've been doing in terms of engaging with our population.
Okay, so thanks, Rosie. So hi, everybody. Just to say, I came to LPT at a very exciting time as they launched their public consultation into the service changes they were making. And we called that consultation Step Up to Great Mental Health. We were consulting on our urgent and emergency care, which we're talking about today, but also some of the changes we wanted to make across the whole of the patch, which Rosie's just gone through with you. So how do we reconfigure what we're offering to people so we service the equality agenda? So just to say that the Step Up to Great Mental Health, there was a lot of work going on preceding this consultation for quite a few years. And we ran it in the summer. And just to say that the CCG led this consultation on our behalf, and we were very lucky in this way because they'd just come off the back of another big consultation to the reconfiguration of the hospitals. And what that meant for us as LPT was that we were able to benefit from the CCG's enormous intelligence that they gathered from that consultation. We reached about 6,500 people with this consultation, and about 3.5 million people were engaged from our counters, and 2.5 of those were from social media alone. Underpinning that, really, the work that I think is interesting for this group today is that we ran lots and lots of meetings, most of them online like this one. Over 100 events were staged. And a lot of those were with our community groups, and a lot of those were by our community groups. So the big thing, just to mention a part of this consultation, that we paid 40 voluntary and community sector organisations to do the consulting on our behalf, because we realised that some of the groups that we wanted to talk to don't talk to us. There is a certain stigma about mental health. I think we've talked about some of those things already. So we knew we couldn't reach these populations, so we paid these groups to do the engagement for us. We had a celebration event 2 months ago with the voluntary community partners that came and took part. We had organisations from the Polish community, from the South Asian health groups. We had the Somalian community, we had the Council of Faiths, the Black African community, the LGBT Centre, and representatives of the blind and deaf communities. So we went across the whole of our patch to engage. And at this event, it was really interesting because we did some videos, which I can share with you all. And every partner that I spoke to at that event thanked LPT for the opportunity to get involved in this consultation and having the opportunity for their members to feel like they were being heard. And the chief exec of the Shaman Women's Centre said she wanted to thank LPT, and she said our ladies don't always get an opportunity to have a voice. And I think that really just is a testimony to some of the work that went on during this consultation and the effort that was made to go out to different organisations. And the legacy of this, and obviously the pressure of this now, is that we need to continue with this. And we're meeting with the same audience again next week to plan how we're going to make sure that this consultation carries on. And just as a footnote to that, Rosie and myself are currently working with quite a few of these partners now as we move into some of the delivery of her urgent and emergency care work. So it's been a really successful consultation, and I think I'm handing over to Helen now, who's going to talk about the services that we're developing.
Yeah, thank you, Louise. I think it's really important. We've captured so much fantastic feedback and engagement, and the willingness, but also sharing with us what's not worked for individuals, personally, but also for the communities they're representing. So the outputs from the all of the transformation work that we've been doing over the last few years, the consultation, are really informing our development plans to address our health inequalities and to really just improve accessibility across mental health pathways. And I'm just going to walk you through some of the key areas of work that we're focusing on at the moment. So I think most of us will have connected with the work with regards to a sort of 24/7 urgent care mental health helpline. We started that last year on the back of the response to the national pandemic. We're working in partnership with Turning Point, with peer support workers offering telephone support, very much wanting to build on the outputs of the consultation, engage with our service user and carer groups who are, and get their feedback from how it feels to access that in terms of, sort of waiting times, information that's available, looking at how we can offer better sort of telephone interpretation and translation services, working in partnership with the local sign language service and British Sign Language interpreters as well. We've also used the central access point to ensure that we've got really clear pathways of care. We've got 3 universities within Leicester, Leicester and Rutland. We want to work really closely with the student population as well to ensure they, when they're studying and they're accessing, that they've got access to the support they've needed. one of the things, moving on, crisis cafes, I think we've historically been quite limited in our availability of crisis cafes across Leicester, Leicestershire and Rutland. So we have used this opportunity with the outputs of the consultation to expand our crisis cafe offer. What we have done is therefore made sure, as we've expanded the crisis cafes, we're actually targeting those in our sort of highest demand areas. So as we've rolled out, I think we had one in the central city centre, we've been able to roll that out into other areas across Leicester, Leicestershire and Rutland, because you've seen the geography is vast. It can take an hour to drive from one side of the county to the other. We've also looked at some particular groups. We've got a large veteran population within Leicester, Leicestershire and Rutland. So we've also expanded some buddy-to-buddy crisis cafes to support the veteran community, and that's been really well sort of taken up, and we've got that advertised in lots of different places. We are also planning to work more with our VCS partners, as Louise has described, to really think about our next phase of crisis cafe developments and look at where we need to target those as we roll those out across LLR. Again, mental health urgent care hub. People will be familiar. The request for alternatives to A&E is something that I think we've been really proud of, the successes we've had for the establishment of the urgent care hub in LPT. Last year alone, we were able to, I think, divert over 4,000 service users away from A&E, or even actually prevent them attending A&E, and they were able to get the support they needed within the urgent care hub that we've provided in a sort of re-provision of an outpatient department at our main sort of inpatient site. We're continuing to develop that, working again with our communication colleagues, our speech and language therapists, to ensure accessible communication, the environment's the right, they're addressing sensory needs, and that we're also working closely with housing and social care support for people to have those really clear discharge and exit plans for them. Self-help resources, included in there is the link to our trust website and the work that we're doing. I think it was really important that we did have accessible self-help resources available on our website, and again through the consultation we've constantly engaged our service users and carers to help design and build our online self-help resources. These will also be available as hard copies in certain venues, and we are looking to publish them in 7 languages, the main languages that are spoken across Leicester, Leicestershire and Rutland. We're also building within that really exciting interactive map that service users, when we're talking about contact, I think Tim mentioned the importance of your locality and your place. So that interactive map can be used to sort of identify where you need to, what's available in your local area and how you can get support. We've also got a traffic light system poster. The copy is just included in the side of the slide, and there is further information included in the rest of our presentation. That's been something, again, just to help signpost people to make sure they are accessing the right service at the right time, to get the help that they need. Within our planned care teams, we're looking at a big expansion in our mental health practitioners within primary care. We've now got, I think we've got not quite 24, the 24 is the plan number, we've got about 17 currently. We're also expanding our employment support service and integrating within the neighbourhood leadership teams to ensure that sort of getting help in the neighbourhood earlier on is really cemented. Alongside that, we have got an ambition by 2024 to recruit to 75 peer support workers. We've got a really good recruitment plan for them in terms of sort of training and development, so they can move through sort of a role as they come in, and a development package. We're working closely with local radios to promote and advertise our recruitment drive into these exciting roles, and also the work that we do within the local communities to really sort of help break down those barriers to accessing mental health, as Bobby was mentioning in his presentation. So some really targeted work going on there. And then finally, I mean, we've seen a lot of data and we've heard a lot of experiences about inpatients. We've particularly had a very challenged inpatient environment within at the Bradgate unit in Leicester, which is at the Glenfield Hospital. But I'm really pleased to say that, you know, we are progressing our Eliminating Dormitories programme. That's due to be completed by the end of next year. We've already had 2 wards where the dormitories have been removed, and we're down to single rooms. The 3rd is underway. And it's a big programme of work that's really going to help support our length of stay, people's experiences, and running alongside that, we're also looking at creating sensory friendly environments. We've been successful in receiving some additional funding this year to really look at sort of addressing sensory needs, supporting people with autism within our inpatient environments, and we're looking at a range of things to really sort of help promote and encourage that over the next 12 months. So I think that was the end of our presentation. There is further detail included in the slides that we will share out, because it sort of gives you links to all the websites and stuff where you can see some of the work we've been doing. Thank you,
very
Ian.
much. Thank you. Thanks very much. For the audience, just to remind you, these are some examples of the really great work that's going on around the country. The GIRF report itself doesn't contain all the information about everything we looked at or saw, because that again is a summary. So if you've got any questions or anything, please feel free to come back to me, and we will be happy to have a discussion with you or whatever. But these are some real examples, just to show that there are real examples out there which are happening right now. And I'm delighted that you've heard that, and I'm delighted with the work that's going on. We're now moving into the question and answer session. I will try and share this. I'm going to go off the question and answers as they come into us. Please forgive me if you've got a question that you placed in the chat box somewhere, but I'm going to the question and answer one. The first one's about community waiters and urgent admission and mental health factor otherwise, numbers and no targets for breach, unlike A&E. And this is something that we've actually looked at very specifically in the out of area reducing our area beds program, and more laterally in the GIRF program. It's something we've worked very closely with our colleagues in other mental health teams, and Bobby Pratap can probably answer this as well. But we are absolutely saying there should be no discrimination. If you need a bed now, you need a bed now, whether you're sitting at home in the community, whether you're sitting with your family, whether you're in A&E, whether you're on a physical healthcare ward. The same standards should apply, and that's what we're working towards, and we're working towards that being measured. Bobby, I'm putting you on the spot. Is there anything you want to add to that?
Yeah, I would agree. When we've spoken to us, these are the people that I think we're most, they're not on an A&E clock, they're not in a building, they're not safe with someone potentially. And what people tell us they are understandably most worried about in terms of keeping them safe and caring for them. The difficulty comes with targets for those. These people are also very hidden. It's very hard in our national data set to see who is waiting for a bed. There is no such indicator that I'm aware of or way of collecting that data at the moment. So I don't think we're really close to being able to introduce a target for that at a national level, but would very, very strongly encourage that to be as much of a priority as anyone at a local level. And we will look at whether we can start to measure that a bit better in the MHSDS.
And what we've said from the GIRF point of view in terms of trusts is we are saying trusts should be setting up a system so that when a bed's requested, they note at the point when it's decided a bed is necessary, and then report in their board papers the delays on that, which would be a first step towards creating a national database. So it's about local ownership and then building that up.
I forgot one thing, Ian. Sorry, I'm taking your time. There is a national new indicator in the MHSDS that is trying to do that. So it's called Decision to Admit. It's never been in there before, but we encourage everyone to record the time of that. So yeah, sorry to add to that.
Brilliant. One of the key things about data is there's loads of data out there. Trusts have got loads of data. It's very rarely analysed. So what we're trying to get people to do is look at the local trust data Look at their system data, because not all of this is within the control of the trust. Some of this will be about system issues, but look at what's available in the system and then see what that tells you about where you lie, and then which are the right lessons for you to learn. And the next one from Deborah Cundy is about analyze data on readmission rates. Ian, do you want to speak specifically about the work in Solent, and then I can talk more generally about the work we've done looking at that?
Readmission rates, like I said, I mean, are they a real sign of failure, or are they a sign that you did well enough to keep someone back at home for 20 of those 30 days? My feeling and the trust feeling is an extra 20 days in hospital is worth less to the person than an extra 20 days at home and then needing to come back to hospital. We have the option of supporting the community. It's not discharge to abandonment. Clearly, you saw our crisis team is a nice, solid, robust average size and intensity of staff, distributions, etc. So readmission, I don't think, is a sign of failure specifically. I don't think it means you failed to do your job.
Yeah, and the work that we've done on that, so there's no evidence that longer lengths of stay are better for people at all. There's no evidence they lead to fewer bed days overall. There's no evidence they lead to fewer negative outcomes, etc. And serious mental illness is a relapsing remitting condition, similar to diabetes or asthma, but you don't keep people in hospital with diabetes or asthma just in case they have another relapse. You get them treated, you get them home, and if they have another relapse, you get them back in again quickly if they need inpatient care. If you actually talk to people who use services and access services and their families, what they want is quick access when they've got a problem, and then to be able to get out quickly, not to sit on wards forever, just waiting for something to happen. So, and again, as we said, we've got clear evidence that there is it's harmful to be in an inpatient for a long period of time. So all the evidence is that there's very little gain from long lengths of stay. And actually, if you total up the readmission days, people spend fewer occupied bed days in hospital and less of your life. If you're going to have 15 years less life expectancy, how much of that do you want to sit in a hospital, and how much of that do you want to be out in the community getting on with your life? So categorically at the moment, there is nothing which indicates that people are being rushed out inappropriately and coming back because they were rushed out inappropriately. But obviously each system has to look at its readmissions and see what are the lessons to learn from those readmissions. Moving on to the next one, X-axis. I'm not quite sure which chart that related to. So Christopher, whether you want to add something as we go along. Move on then to the next one. The 136s. So we know that 136s are intermittently reported. We know there's different approaches around the country. What we are saying to people is, do you understand your own local 136 data? And, you know, trusts will span several police forces potentially, and there'll be different types of area. So what we're really saying to people is segment this data. Where are these section 136s occurring? Where do the people who have been put on section 136 come from? And then why are they having to present in that way? Why is the system not offering them something else? I saw that some people say it's got intoxication or other things. If that's true, it's still a system failure for that person. It may not be the mental health trust, it may be some other provider, but the bottom line is, why are we not having effective systems for those people? So section 136 is need analysing. In all of this stuff, it's possible with GIS, which I can't remember, Geographical Information Systems, it's possible to map all this stuff down to postcode level. We need to get away from looking at things on an average and not actually saying, which bit of our community do these people come from? Why are they presenting in that way when people from other parts of the community are presenting in different ways? And analyse that. We've spent too long saying it's not good enough, so it needs to change. We need to start making things change. And like I say, what's really encouraging is around the country, there are a lot of places who are making a change, and we just need to make that the majority. Sue Jenkins, due diligence. Same thing. If you don't feed the data back to those who feed it in, you will never get good data quality. One of the things about the deep dives is everywhere we went, they said, some of them look right, some of them look wrong. But it was the first time they looked at it was when they got the data back from us. And often the answer then was very, very clear as to why it was poor, why it was not recorded, why ethnicity was not recorded, why diagnosis was not recorded, why this was recorded, why that was wrong. And if we want to be serious about planning and delivering things, we have got to be delivering services that are relevant to the people we serve, which means we have to know who we're serving, and we have to know which things, which interventions for which types of condition have the best outcomes. So we've got to get data right, and the best way of doing that is feeding it back to the people who fit it in so they can see it's been used, and then trust publishing that publicly. And national data can also be published, but it's really important trust own that and publish it. And as we move into ICSs, that the ICSs are holding that and publishing it. So we would expect ICSs to be doing a report on how many people end up stranded in hospital for more than 60 days with a mental health condition. At the moment, it's 90 days for older people. But we would want to say that's a system issue. Why is this ICS not tackling that? That's a quality issue. It may save money if you reduce that length of stay, but that's not the prime aim. The aim is to reinvest that money in the community, so it's not an overall net saving. But why are we subjecting people to those long lengths of stay? So that's due diligence. Moving on to the next one, mental health urgent care hub. I think that's for Leicestershire. Anyone want to pick up on that?
Yeah, thank you so much. The Urgent Care Hub is open 24 hours a day, 7 days a week. We continued to staff it since it was set up in beginning of April last year. It's not a walk-in service, so it isn't an alternative to A&E from a self-referral perspective. Referrals are accepted by our local ambulance trust, crisis team. We'll get transfers from our telephone central access point. Anybody who does use the sort of self-presenting via the Leicester Royal Infirmary, which is our main A&E, we're able to, using our liaison team, divert them up to the Bradgate unit to use our hub, and we do provide transport to and from that as required. It's staffed 24/7 with a mixture of staffing. We've got registered mental health nurses, we've got some healthcare support workers, we offer training experience for student nurses, we've got staff grade doctor across sort of core hours, the week and the weekend, and then out of hours support from our medical training rota for access to psychiatry.
Thank you.
So that's how we've been running it.
Thank you. I'm conscious that more questions are coming in, so I'm just galloping on. Like I said earlier, if people have got questions that we aren't able to answer, my details are on my slides, so if you want to send things on to me, I can certainly respond even after the meeting. So don't worry about that. We will be able to answer any questions. Drug and alcohol services, yes, even the government has acknowledged that the money they're putting in is to help partially restore the cuts that have happened over the last 10 years. So there is a recognition at national level from government statements yesterday that there's a lot of work to do to get alcohol and drug services up to where they need to be. Yes, they are a huge component in the system response. So whoever is the provider that's providing them, the question is, are they integrated? Is the system working well together? And that was incredibly patchy across the country. So, you know, that is a really live issue, and I think that was incredibly patchy. And there are pros and cons, and we can talk about those as well at more length if people want to follow up with me on that. Older adult and dementia beds for acute patients when desperate. Amanda, do you want to pick up on that?
Anecdotally, I have heard that. Interesting. I just want to point out that all that wonderful data that Bobby described also can be cut down into over 65s, and so it's really worth looking at. And again, for out of our placement, Advaria placement, sorry, you know, there are some areas with significant numbers of older adults, so it's definitely worth looking at. As I said, I can't tell you the numbers, but anecdotally, I have heard of that happening. That the beds are used by working age adults when desperate.
Thank you. And the next two are for Ian McCaffrey. Ian, one is, can you speak about how you supported the culture shift and some of the hurdles you've experienced? And the second one is, your length of stay is very low. Do you have any data picking up on patient family satisfaction, whether you're discharging people too early?
Culture, you can't tell people how to be culture. The trust has values where it's a peer respect, it's a multidisciplinary decision. These aren't new words that mean anything other than normality for most people, but it does mean that there's a trust that shares responsibility for your work. If you're there and you're qualified and you've been employed into that role and you do something, then you're entitled to do it. You've done things right. If you're a doctor and you need to ask a psychologist, you trust the psychologist's opinion. It's a culture where the doctor doesn't discharge, the team discharges, and I think that's the culture that has changed. The doctor just happens to be the person named on as the responsible clinician if they've been a detained patient, but it's the team that discharges realistically. And the second question was patient feedback?
Patient and family feedback as to whether people feel discharging people too soon.
Patient and family feedback is, I'm sure, one of the holes that data is always desperate to collect validly. Family and friends tests are very, very poor. Our patients, if they get readmitted, always say, can I go home again? So they prefer to go home, which is a sort of brutal measure of going home. And no one goes home without the families having been involved in that discharge plan. So they're part of the process, assuming there's family there.
And from the national work, what we picked up very strongly is that it's about the length of time it takes to get people into hospital when they need it is the big problem for families that are often left. And not just for families, but also for housing providers who are often left with people who are very unwell, waiting on a bed. And that is the really difficult time. If you can get someone into hospital quickly and get them out quickly, people are usually happy with that, particularly if you can get them in and out before any secondary harms have occurred. And what we know is that places that have got the easy in, easy out are much less likely to have out-of-area beds and are much more likely to have a bed available quickly for a person in the community who needs it. And that's the critical bit. The burden for most families is getting action at the beginning and not taking the loved one back when they are improved.
Yeah,
so
I'll add to that. I mean, our occupancy is relatively low. We don't have out of area placements, which means people come in so that friends and family aren't distressed by the level of illness as they arrive, which means when they go home, firstly, they know if they need to come back, they will come back, but equally, they've not got this fear that they will wait with a family member who is acutely ill now that they're home. That we won't have to hold that risk at home as family. If necessary, this is a short-term stay. Like I said, there's the option of readmission, which means that people aren't fearful of it. So that's probably the family feedback. That is probably more anecdotal than data-led, but Ian, if you have it.
No, but also in terms of anecdotally, what we know is that places with high detox, as delayed transfers of care, difficult to get people out, it's often because they've been left with housing providers too long, so the housing providers become very reluctant to take anyone else from that place. And again, the feedback from housing providers, I did a webinar on this a while ago, is that if they know that someone will be readmitted, if they're starting to reach a crisis severe point, quickly, they're much more willing to take people on. If they think they're going to be left with them and perhaps their flat's going to get trashed or whatever, then they're very reluctant to take them on. So it directly links into detox rates as well. Next one is about staff challenges. Yes, one of the good things about the long-term plan is it's created lots of new roles, which are really exciting, and that hopefully will enhance our community offer. One of the downsides of that is that lots of teams are complaining that they're being stripped of staff because they're all going off to these new roles. I know Bobby's still here. I know there's a huge workforce thing going on in terms of the mental health workforce. Do you want to say anything on that, Bobby? Putting you on the spot again.
Yeah, I mean, workforce is an area I've covered loads. Other than that, I think we are increasingly saying that with the mental health investment standard money, it's often badged as being for recruitment, which it obviously is, but it's also to keep stuff. So we are very much encouraging all the long-term plan money, the winter money to focus on retention as well as recruiting new staff. And I think we're working with colleagues to try and get as many examples of initiatives, small ideas, things like having a chair in your office that we felt is, or big recruitment things like looking at people's pensions. We're trying to get all of the ideas that we can share more and more of everywhere. That's all I'll add on that for now.
And what's true around the country is that all the trusts that we've been to visit are actually looking at a whole range of different types of role and different ways of bringing people into the workforce, which are not traditionally part of the workforce. So we have to be open to that as well. We have to look at electronic and other types of things that can help. But yes, there is a national shortage. Every single trust you go to is competing in the same pool for a dwindling number of staff out there who are available. What's really, really critical to that is your staff satisfaction rates. And I think that's one of the most important things that trusts need to be aware of, is that low staff satisfaction rates generally over a year or two will change into high turnover rates and low recruitment rates. So really important that you're actually positively feeding back to people. Bobby? Oh, Amanda, sorry.
Just saying that we were discussing this the other day, and the topic came up, and people were saying the number of people who say I'm going to leave, and everybody goes, oh, bye, and nobody says, well, what would make you stay? Is there anything we can do that would make you reconsider? And actually, isn't that amazing? We don't ask with this problem. We don't ask people. It's about actually, treating people correctly.
Totally agree. We've got 3 minutes left, and we've got another question here about the urgent care hub. It's about, I think it's more general. It's about, are they going to reinstate urgently over the winter? Bobby, is that a national policy one rather than a Leicester one?
It's not a specific national policy at the moment that we're asking every area to do so. I think what we are conscious of is how severe pressures are and how they might get worse in the peak winter period. And everyone has been asked to look at preparing what else they might do to support those pressures, but it isn't a specific diktat that and it never in fact was, even at the height of COVID. A lot of people think we said everyone must stand those up. It was more of a consider that if you think it would be useful for your area. So I think the answer is no.
Okay, Bill. And the last one then is readmission rates not linked to quality of care, maybe too simplistic. Absolutely, it's far too simplistic. Readmission rates, like I say, you should be looking at who's coming back in and why. It often links to the quality of the community services and what you're able to offer in the community. But we're not saying ignore readmission rates. We're saying look at your readmission rates and see why people readmitted. But keeping people in hospital as a way of trying to prevent readmission rates is not effective. That's what we're saying. And thank you very much. We've got 2 minutes to go. So thank you all for attending. Thank you for the speakers. Great examples of what's going on. Lots more examples we can give. Like I say, you've got to get the whole webinar. Anyone who wants to follow anything up, you'll be able to. But thank you very much. And with 1 minute to go, we'll wrap up and say thank you and goodbye, everyone. Thank you.